Every minute, someone's life takes a terrifying detour, not down a dark alley, but into the sterile, bright halls of healing. They walk in seeking care and find themselves plunged into a nightmare. Most malpractice claims in hospitals are related to surgical errors, whereas most claims for outpatient care, which accounts for more than half of the paid malpractice claims, are related to missed or late diagnosis. Now, before you raise a pitchfork at every white coat you see, let's be clear. This isn't an indictment, it's a revelation. Because the truth is, any provider, any nurse, any human being capable of brilliance is also capable of a mistake. This is about understanding why and using that knowledge to build a safer future for every patient who walks through those doors. Welcome to FHEA's Scrubs and Subpoenas, Tales from the Witness Stand, a podcast where we'll peel back the sterile sheets and delve into the real stories of medical malpractice. Each episode, a cautionary tale, a blueprint for change, a reminder that even in the darkest corners of human error, there's a light. The light of knowledge, the light of empathy, the light of a future where healthcare becomes not a gamble, but a guarantee. So join us as we dissect the mistakes, illuminate the flaws, and ultimately learn to heal not just bodies, but the very system itself.
Hello and welcome to another episode of Scrubs and Subpoenas, Tales from the Witness Stand. I am your host, Jonna Emil, and joining me again is one of our expert witnesses and very amazing FHA faculty, Dr. Sally Miller. How are you, Dr. Miller?
I'm very well, thank you. And you?
Excellent. Thank you. I'm really excited to hear our next story. For those of you that might be joining us for the first time, this is a new podcast that we've been running here, and it's a really interesting new podcast series that we have and a really interesting way to learn, right? So we want to make sure that we take the time to say that we know, right? We know that mistakes happen all the time, right? And no one is immune to it. Dr. Miller actually has a really good phrase, a saying that you used last time. You said that there's those of us who made mistakes, right? And those of us who will. And I think that that's a really good way to kind of like ground us, right? So we're not throwing out judgment. It's easy to look at things that have happened in the past and say like, well, this should have gone this way. But it's a really good opportunity for us to hear real stories that we all know as practitioners, as clinicians and providers that happen, and kind of dissect them together and take it as an opportunity to learn how we might be able to do better in the future, right? Is there anything you want to add to that, Dr. Miller?
I don't think so. It is definitely not a judgment-oriented approach. It's really, how you learn. You go back and learn, like all of those, root cause analysis and all of the names of different mechanisms for just trying to ensure that we don't repeat the same mistakes.
Excellent. Perfect. So with that said, we are ready for our first case. And so those of you that are listening, and maybe you've heard this or didn't hear this for the first time, listen and follow along, right? Listen and follow along and see if you can catch maybe where there might have been some room for different opportunities, different decisions. So I'm ready when you are, Dr. Miller.
Okay. And I do, so sometimes time and timeline is really important, the nuances of the timeline of events. So in some cases like this one, I have some notes in front of me just because I want to be very precise on the timeline. And I think what I'm going to try not to tell you who retained me, whether it was plaintiff or defense. Let me just tell you the narrative of events, and then everybody can give some thought to what's going on here and what they think was the standard of care. And then at the end, we'll Q&A it. So the story is this. It's about the patient is a 60-year-old gentleman, actually works as a medical assistant. And he had been seen in the emergency room on 2 different occasions within a 2-day period. He had an injury at work. Something happened in his role as an MA, something to do with moving a patient, a physical thing. And he had back pain, abdominal pain, and vomiting. And he went to the emergency room twice in a 2-day period, like I said, and they diagnosed him with sciatica. And he was basically, managed for pain and given some suggestions about, exercises, PT, that kind of thing. On the 3rd day, he went back to the emergency room and he was complaining again of back pain, abdominal pain, and vomiting. And so the emergency room physician who examined him at this point noted some abnormal findings during the abdominal exam and the lower back examination. So following that exam on this 3rd visit on the 3rd day, the physician ordered some laboratory tests. He put the patient on IV fluids, pain medication, an NG tube was inserted, and 200 mLs of bloody drainage was drained. So, needless to say, they kept him around for a little bit this time. So that was actually the admission and the initial examination and the NG tube, etc., around 4:30 in the evening. At 6 o'clock, an hour and a half later, an obstruction series was ordered. And then some of the labs started to come back, and the patient, of note, the patient had a total leukocyte count of 25.9 thousand cells, which is elevated. He had obviously, right? He had neutrophils of 90%. He had a serum amylase of 1202. Other atypical lab findings included a BUN of 49, a creatinine of 1.7. Now, we don't know where he started. We don't know what his baseline was, but that's what was determined on that night. He was medicated for pain, and then again, he was medicated for pain a little bit later. So, needless to say, shortly after this collection of lab tests came in, the patient was admitted to an internal medicine service. So technically admitted, but you know how it goes in the ER. Sometimes you're admitted to a service, but you can stay in the ER for, a day or more pending availability of a bed. And so he was admitted to an internal medicine service. The internal medicine service to which he was admitted, the internist was unavailable. So another internal medicine service was covering for the admitting service of record. The covering internist was out of town, and so the APRN, who is, my interest in this case, the APRN was covering call for the internist that was covering for the other internist.
So she was like covering for the covering of the
for the covering
person?
Yes.
Okay.
We have like what do they call like 6 degrees of separation,
yes.
like the whole Kevin Bacon thing, right? So boom, boom, boom. So this APRN, she was not in the hospital. This was I believe it was a Friday night. It was a Friday night, and she was at home, and she was taking call. So she picked up the phone. So she was the one that got the call. So what we do know, now remember, all of these things always happen years after the event. By the time everybody's looking at charts and, pleadings have been filed and records are subpoenaed and everybody's looking at it, it's years after these events actually occurred. So what we do know from deposition of the emergency room physician is that he spoke to the covering APRN by telephone. There is no record of this phone call anywhere. There is no recollection of the phone call. The physician was a he, and he doesn't remember what he told the APRN, and she's a she, so just for the sake of brevity, I'll probably use the pronouns here. He doesn't remember what he told her. He didn't write it down. He did document that he called, or there was a note that he called her, but there was nothing to memorialize that conversation. She did not remember this call at all. She didn't remember anything about it when she was deposed like 4 years after the events. And so he doesn't know what he reported to the APRN. She doesn't remember the call at all. And no one else can recall anything about information of this phone call. So, okay, just like put that on the back burner for a minute. This, if nothing else, just side note here for all of us to make a call like that, it's probably helpful to jot down the pertinent stuff. And listen, I know that it is difficult, and I know when you're running late, and the last thing anybody wants to do is sit here and write a whole 5-chapter volume on the nature of the phone call. And that's not what I'm suggesting, but just maybe real quickly, like the highlights of the pertinent that you report or whatever, and what that person says. Okay, so we don't know. That's what we're working with now. And that was at about that happened around 6:30. It's recorded at 6:18. So the timeline here, he comes in at 4:30. He's got the NG tube with the blood. He's got some abnormal abdominal findings. Labs are ordered. An obstruction series is ordered. The labs start to come back around 6 o'clock with this very high white count neutrophilia, very high amylase, elevated BUN and creatinine. That was about 6 o'clock. The patient was medicated for pain, and then at 6:18 was documented the decision to admit him. So this is when this telephone call is happening. Now, we do know, nobody knows what happened during this call, but we do know that according to the chart, the labs were available at that point. The obstruction series was not, because the obstruction series was resulted later on in the evening. So he may or may not have shared with her some of these labs. Nobody knows. And blessedly, nobody was as you read through the notes and read through the depositions, everybody was just very frank about, look, I don't know what I did on a Friday night 4 years ago. Just like we don't know what we did Friday night 4 years ago. I don't know what I
Yeah.
did this last Friday night,
Yeah, no
but that's
kidding.
when you go back and look at the written word, there was very little there. We do know, next thing that's recorded of interest is at 8:24 p.m., the obstruction series is dictated by the radiologist as suggestive of an early or partial small bowel obstruction. No one was advised of this result. Usually the radiologist will make a note, reported to attending, reported to floor nurse, reported to ER, whatever, but there was no note that anyone was advised of this result. So again, was it called to somebody or not? We don't know. The report was not transcribed until the next morning. So that's just out there. It was resulted at 8:24, but we don't know if anybody knew about it or not. So the next thing of interest in the record is that at 9:40 p.m., the emergency room nurse calls the APRN because she's covering the admitting, right? So
Yeah.
the ER nurse, the patient is now in some sort of status, like they had this ER status hold or something. So they're calling the service for orders, but it's the ER staff that's managing it. Well, whatever. So the ER nurse calls the APRN to request a pain medication, and Dilaudid 1 milligram was ordered. The nurse again called the APRN 5 minutes later asking for an order for severe pain. And so she ordered 2 milligrams of Dilaudid PRN severe pain.
Or Dilaudid. Okay.
At that time, at that time, the APRN also ordered a surgical consultation. Nothing else is documented about the content of these calls. We have 1 milligram of Dilaudid, 5 minutes later, severe pain, 2 milligrams of Dilaudid, and a surgical consultation. It looks like a routine surgical consult. At least there was nothing ordered stat or nothing recorded that was ordered stat. So this is now 9:40 p.m. on a Friday night. So the surgical consultation did not happen that night because it wasn't ordered stat, reportedly. At 11:45 p.m., a new nurse took over. Nothing else was recorded that night. The APRN was not called by nursing or house staff. The APRN was never called again. This is the entire interaction of the APRN with any staff or anyone about this patient. She got a call at 6:18 from the emergency room physician. She got a call from the floor nurse at 9:40 and then again at 9:45 and gave orders for pain meds and a surgical consult. Again, there is no discussion or dialogue in writing about the content of the call, the nature, were any other pertinent findings pointed out, was anything requested. We just don't know. And that's it. The APRN never heard from anyone again. So I guess she went to bed. The next day, the attending physician with whom the APRN worked, the covering attending, he was back in town, right? So the person whose service it actually is still has nothing to do with this yet. Now the next morning, Saturday morning, it's the physician with whom the APRN works. He's now available, and he goes to the hospital and he rounds live. He does live rounding on the patient, and he felt during his physical exam that a small bowel obstruction with a perforation was possible. So, and apparently at that time, he became aware of the obstruction series result that had been obtained the night before. So a stat CT and surgical consult were ordered. The patient was taken emergently to the operating room. In the OR, the patient was found to have necrosis and gangrene from the gastrojejunostomy to the terminal ileum that he had, that nobody appeared to know about. So by the time that the surgery was over, he was left with about 18 inches of small intestine.
Holy crap.
So, needless to say, he lived. I mean, he did. I shouldn't say needless to say he lived. Not everyone would, but he did. But what I started to say was needless to say his life has changed significantly. At the age of 60, as a medical assistant who now has 18 inches of bowel, when you go from something like 15 feet of bowel, or I don't know exactly what the number is, but we have feet and feet of bowel. And now he has 18 inches of small intestine. So it changes your life in every way. The whole as soon as you eat, you pretty much have to be on your way to the bathroom, as you're learning how to manage that part of your life. Not to mention the unbelievable physiologic stress and strain that is placed on a 60-year-old body that was septic, between the gangrene and necrosis was septic. So it was a big deal. He spent a lot of time in healthcare services and recovery and that kind of thing, and never was able to go back to work. Excuse me. So, of course, a lawsuit ensued, and lots of people were named in it, but very specifically, the APRN was named in this suit. And it was suggested that she violated the standard of care. Well, I made some notes. So I made some notes about what the assertion was. So one of them was that when the APRN took the phone call from the emergency room physician, she failed to ask about abnormal test findings and outstanding tests. It was suggested that it was her responsibility to purposefully ask for any abnormal tests that had been obtained, and to obtain the results of the obstruction series that was pending at the time of the call. So the suggestion is that she got the call at 6 to 18. If she was told the obstruction series was pending, it was her responsibility to call back in and find out what it was.
Okay.
So it was suggested that she failed to ask appropriate questions when the ER physician gave a verbal report. Keep in mind that the whole, most of the time, malpractice cases really, really come down to, did someone violate the standard of care? And I'm sure I've mentioned this in previous episodes, but the standard of care for the legal standard of care is very different from the healthcare provider standard of care. If you ask any nurse practitioner what the standard of care is, they'll pull guidelines out. They'll tell you about, this is what this guideline says, this is what the evidence says. And that's not the legal standard of care. I'm sure I told you before, I learned the hard way. The legal standard of care is what a person of the same licensure would do, or same licensure, experience, etc., would do under the same or similar circumstances. So, and I don't even know that there is an evidence-based guideline about what you're supposed to do on call. What do you do when you're home and you're answering the phone for somebody and it's a weekend and they call you about a problem and apprise you of it and pretty much tell you what's like, we've admitted him, etc. What is the responsibility there? So that's really the question. What did she deviate from the standard of care? Did she fail to do what any reasonably, appropriately trained nurse practitioner would have done in the same or similar circumstances? It was also asserted that this nurse practitioner failed to ask appropriate questions when the nurse called her at 9:40 and 9:45, asking for orders for pain and then again for severe pain. The assertion is she didn't ask enough questions. She didn't pursue why this pain was happening or why do you need it for severe pain, any of that. And then finally, it was suggested that the APRN should have asked if the patient had a history of gastric bypass surgery or any sort of gastric surgery. So
Oh
that's
my
the assertion. That's the assertion, of course, from the patient's attorney, that's what they're asserting that she did wrong. So interestingly, I really think it's an interesting question, actually. So you probably can tell I was trying to be all slick and objective here, but you can probably tell that I was retained by the defense. And
Yeah.
that really doesn't make any difference. I have turned down defense cases that I didn't feel like I could support. And I have testified for plaintiffs, and I've also turned down plaintiffs' cases that I felt like I couldn't support. So I really, unlike many of my peers, I really don't have any particular preference. I think that if we have a nurse practitioner who's violating standards of care and being unsafe, I think we want that drawn to their attention so that they can either remediate their practice or not do it, because it's no good for
Absolutely.
patients and it's no good for the profession. So I don't take sides. I'm not, a defense person or a plaintiff's person. But in this particular circumstance, I thought these were some interesting questions. Who does have what level of responsibility? And of course, since virtually nothing here was recorded, what they will accept many times, what is considered acceptable testimony, is when someone testifies, this is my custom and practice. This is what I would do if
Yeah.
X happened. So what she said was, now the APRN testified clearly she had no recollection. She didn't remember this at all. She was
It was
not in a
so long
position to
ago,
be.
right? Like
Yeah,
that
it
was
was
the big
years
point.
ago. I mean, it was a Friday night phone call, and she didn't have any, and didn't memorialize it anywhere. Didn't have it, I mean, this was a long time ago before we all had ready access to charts and laptops that had records on them. And even at that, I don't know. I don't even remember how things were at this time, but it definitely was not that easy. And then, of course, you have the whole HIPAA thing about you can't be pulling up medical records on your personal laptop. So
Right.
this is like, it's just so, is it how cut and dried is all of this? So the things that I think that, I mean, the question for me was, did she deviate from the standard of care when she didn't do those things? I mean, it's the defense's job to answer, to defend themselves against the assertions of the plaintiff. So the plaintiff is saying she didn't ask enough questions during the initial report at 618. She should have called back to check on the obstruction series if she knew it was pending. She should have asked more questions about why there was pain at 9:40 at night. And it was also suggested that she should have ordered that surgical consult stat, and she did not. And all she could say in her testimony was, "Look, I don't know what you're talking about. I have no idea what you're talking about. Unfortunately, I don't have any recollection of two phone calls on a Friday night 4 years ago, but I can tell you my custom and practice would be that had I known about a white count of 25.9 thousand, had I known about an amylase of 1202 and neutrophils of 90%, I would have ordered further evaluation." And so, the question, and hopefully people are listening are wondering, really, where, think about the practical application here. You're at home, it's Friday night, you're on call, you're covering for somebody, phone rings, hello, oh, it's the ER. Yes, we have this patient. Here's the dialogue. Okay. And they hang up, and then hours later, 3.5 hours later, the patient's having pain. Okay, give them some Dilaudid, having more pain, give them some more Dilaudid. Where does the responsibility lie? So who
Wow.
whose responsibility is it to give information? I mean, is it acceptable to say that the APRN is just the receiver here, and whatever information is presented, that's what she works with? Or is it her job to ask more questions? Is it her job to pursue that a little bit further? Whose responsibility is it to make sure that information is given to the covering person on call, that they can make appropriate judgment calls? That's one thing to
Wow.
consider. And I guess that's really the big thing when push comes to shove. So if we only had like mystery music, maybe we could play mystery music now and people would think through this. But I mean, really, so from a defense perspective, primarily, just because nobody wrote anything down doesn't mean that information didn't change hands. You know,
Right.
um, do you write down? When anybody makes a call, is it the standard of care to write down every little thing you say?
Well, it's like, so it's two things, right? It's making me think of, and it makes me think of the old like line, like passing the buck, right? And it's like, well, it wasn't me, it was you. And it's like, well, no, it wasn't me, it was you. I gave it to you. And it's like one of those things that we talk about sometimes. But in my mind, right, and I don't know, this might be not right, but I feel like if you assume, this makes me think about one of our episodes, quite honestly. If you assume the role of the provider, right? Even if you're covering for the covering of the covering, like at any
Hmm.
point you're playing provider, then like it seems like you have to be full on provider. So like what would a full on provider have done? And I hate to make it seem like she wasn't the full on provider, but she assumed responsibility, it
Hmm.
seems. So if you assume responsibility for any patient, then I imagine you're going to do all the things that you would do for every patient, make sure every T is crossed and every I is dotted in that way. And then without the documentation, this makes me think of every single time a professor has like drilled documentation into our heads as like nursing students, how freaking important it is to document, because that's the whole thing. If you didn't document it, then like something happens. How do you go back and show anything? You don't. But then I think about, that was so many years ago. Even if you did document it, how long does documentation live? Now that's like the new thing I never even thought about. There's like a lot of layers to that.
All of the above. I mean, now it's like documentation just lives to infinity. I guess unless we have some major, major devastating cloud crash or something and everything
Right.
will be gone, it's like everything is available on the cloud. So, I mean, I really, I'll tell you, listen, I was retained by the defense. So,
Yeah.
I mean, I don't know how to say this because I want to accurately represent my thought process. It's not like I go, oh, I'm going to say whatever I have to say for the defense. Like I said, I've turned down cases when I feel like I can't defend them. In this one, I really had to think about what is that the legal standard of care, what the same licensed person would do in the same or similar circumstances. What, I'm like, what did I do when I was on call? And I got a call from a facility and they told me something and I had to give a response to it. How much digging do I do? A typical, like what someone would do in the same or similar circumstances. I'm kind of jaded now because I see things like this. So my documentation has changed over the years. My approach to anything has changed over the years because I've seen how these questions arise,
I
years
feel like
later.
you are hyper documenting now.
Oh, I'm sure I said another episode. Everybody makes fun of my documentation because it's like, it's like almost reading War and Peace. It takes time. I really do go
Yeah.
back and I just write every note as if three or four people are going to be scrutinizing it with a magnifying glass a couple years down the line. Because, I hope it doesn't happen, but it could be. In this case, though, I really did struggle with envisioning this dialogue in a real world day to day. I mean, I definitely do not think it is the responsibility of the receiver of the call who's, at 6 o'clock at Friday night, probably home having dinner or something, gets this call from the ER, from the person who is on site, the person who evaluated the patient, the person who ordered all of these things. Like that person presumably knows all the relevant info and is calling
Right.
to give report. So I definitely believe that the primary onus of responsibility is on the person who's made the call to admit the patient and then is passing that on to someone else. I mean, when you give report, you tell the person who's going to take over what they need to know, right? I mean, even nursing report was that way.
Yeah.
But and so the APRN, we don't know what she was told. That's
Right.
the
Because there's
thing.
no
We don't
documentation, right? There's
know
no
what
record
she
of
was told. I mean, we don't know. And so it all becomes what if, what if, what if. So remember, this man had been in there 3 times in the last 3 days after an event at work and got some back pain. And for 2 days had been diagnosed with sciatica. So we don't know if when he gave report, he said, look, this is, this man's 3rd day here. He's been treated for sciatica, but it seemed a little off and he's back. So I ordered these other things. We don't know what results he gave her or not.
Right.
We don't know. I mean, you might say, oh, well, don't you think he would tell her about the blood? Don't you think he would tell her about the white count? Well, yeah, but I have learned, don't ever assume what somebody else did or didn't do. Because also vision those emergency room nights. 5 million things are happening. Somebody's coding
Mhm.
here. There's a femur sticking out of somebody's leg over here. Somebody else is out sick. Everybody's overworked. This ER doc is in the middle of like some other major thing. And somebody says, oh, hey, that internal med's on the phone for this guy. Oh, hey, look, sorry. Just wanted to let you know we're admitting this guy to your service. Blah blah blah. See ya.
Right.
Or not. We don't know. So, when it comes down to something of this magnitude, to say things like, "Well, don't you think he would have done this, this, and this?" A lot of times, people reviewing this stuff suddenly get very like high horse and, "Well, I would have done this and I would have done that and everybody should have done that." And that's just not real life. So at the end of the road, if it's not written down and nobody remembers it, you can't say what somebody did or didn't do or what they should have done. All they can say, it's their custom and practice. So the ER physician may very well have testified, it would be my custom and practice to pass on this info. And the APRN, I know she testified, well, it would be my custom and practice if I received this info to do X, Y, and Z. And
Yeah.
since nobody can support what went where, like we just don't know. 3 hours later, she gets a call about the pain. So what is how much do you ask? So now at this point, we're not talking about like a peer-to-peer report. We're talking about the APRN getting a call from the covering nurse asking for more pain meds. At this point, does the APRN have the responsibility to dig any further? Like, well, why is he in so much pain? Or, I mean, again, I don't know. I'm not sure. We don't know what the nurse said. We don't know what the APRN said. Nobody knows because nobody wrote it down. To some extent, I still do believe that the person making the call is the person on site, on board, with whatever information prompted them to make the call. And you would assume that they would pass on appropriate info, but again, like nobody knows. So
That
it almost reads like, oh, so and so is having pain. Can I have a pain order? Yeah, give him 1 milligram of Dilaudid.
right.
Is that right? You know?
And it's like, maybe, but like you don't have all the right information, right? And I think that's a really interesting point because you're right. I am honestly sitting here going like, oh, she could have asked this and she could have asked this and she could have asked this.
Mm-hmm.
But that does now feel like a slippery slope, right? That makes me even think about every single time I've received report, I counted on the nurse to give me all the information. Granted, there'll be some things I will find out during my own assessment and like my own care, but I didn't also go, well, what about this? And what about that? And what about that? And what about that? Like, you know what I mean? We didn't do that because I assumed that you gave me all the information I needed
Mm-hmm.
to carry on and take the next step for the patient. So that is so tricky. And then, so are there not real best practices that exist around things like this? Like, what is the responsibility if you're on call and you get a call on a Friday night, let's say super late? Like, what is your responsibility? I think of everything as like this checklist, to go through to make sure
Yeah.
like you're nice and safe. But I know that we're not cut and dry like that. We're just not.
No, I mean, there's no evidence-based standard like that, like there is with a hypertension algorithm or an asthma algorithm or something
Yes.
like that. It really much more generic. The on-call provider, should provide blah, blah, the kind of language that doesn't really
Yeah.
provide. And for the most part, I think the facilities might have their requirements for on-call, but even that is just very esoteric and covers all bases. So I mean, the one thing that I think was absolutely absurd was that she should have purposely called back hunting down the obstruction series report. If she even knew one was pending, and we don't know, but if she knew one was pending, it is reasonable to assume that if there was an alarm finding on the obstruction series, that someone in the hospital would have passed along that information to people that needed to know it. You don't just
Yeah.
expect somebody on call to start making calls, hours later to hunt down the result of a report. But that one was clearly absurd. But the others, but so I will share with the listening audience at home that this APRN was not found liable for malpractice. There was a
Wow.
settlement. There was a settlement from other providers to this patient and family, but she was not among them. I like to think it was because of the expert witness who defended her in deposition. But honestly, the fact is, when push came
Wow.
to shove, there was just absolutely no record of what she was or wasn't told. And the one thing that I think everybody did seem to agree with was the people on site, the people that make the call to bring you into it, do have the primary responsibility for ensuring that all relevant information is communicated. And if they don't, and if nobody writes it down, and you can't know, well, how do you make that judgment? And in this
Wow.
particular case, yeah, so she was not found liable.
And I wonder, and what do you think about this? You know what it makes me think about? Like our rights of delegation, like
Hmm.
what we learned about, like, as nurses, right? And like the right way to delegate. And part of that, as you're talking, is making me think about like, you can't just give somebody something to do or to carry out without all of the right
Hmm.
information so that they can actually perform that. So that's actually kind of interesting for me because I feel
Hmm.
like that puts it into perspective in a way that I never thought about that, like, of course you're qualified to do this, you're a provider, you can
Right.
do all of these things, but also there is still a responsibility and an onus of everybody on that team, on that
Hmm.
conveyor belt, to keep passing along all that information. And unfortunately, there's a patient at the end of this.
Exactly.
Yeah.
A patient whose life changed.
Ah, oh my gosh, that is really interesting.
So,
Wow.
I mean, like I
Is
said, when I call somebody now, I do just a few elements, just a few pertinents, but I make sure that it's in my note. Who I called,
Yeah.
what happened, or that they didn't call me back because that happens a lot too.
Yeah, no,
Mhm.
that's a great takeaway, to ensure that
Mhm.
that still counts, and that's still part of documentation. That's still part of, patient documentation.
Mhm.
That's really important. Wow, Dr. Miller, that was a really interesting one. Is there anything that, like, we haven't covered with this, and important takeaways, something to think about that you'd like to leave our audience with?
I mean, other than what we've talked about, I mean, number one,
Yeah,
it is a really interesting hole in our well documented standards of care. Maybe somebody doing a
yeah,
DNP project or something like that really might explore is there any evidence-based foundation for the responsibilities of an on-call provider? And if there's not, it might be a need that, like I said, a DNP student or somebody building a career might look into. It sounds like publishable work. And then for the rest of us, it's just the little things. I mean, we none of us have time to document War and Peace. I know. But I will say, if I try to, like, the work that I do now, I might reach out to a specialist, or I might, send somebody to an ER and call in to let them know they're coming, and please don't send them home or let them sit there for 5 hours. And just the highlights, just the most important things that you shared, at least does document what you did do.
that's important stuff. Dr. Miller, thank you so much for sharing this story, for sharing all of your stories. It is a really good opportunity to learn and listen, and every single time it challenges something that I thought, like, I was so strong and firm about, and then you realize, like, you know what? Real life is really different than what we learn in the textbooks, and real life is really different than, all the things that we have to do as we're learning. That's not wrong, but there are these pieces that just don't capture until you're in it.
Oh, that whole human factor. That whole
Yeah.
human piece. Yep.
Wow. Thank you so much. And thank you all for tuning in, listening. We hope that you found this story interesting and that you also found it helpful and learned something from this. And if you like this episode and any of our other ones, check out our other podcast offerings that we have going on FHA.com. Goodbye for now.
Thank you for listening and learning with Scrubs and Subpoenas. Tales from the Witness Stand, presented by Fitzgerald Health Education Associates. Please rate, review, and subscribe to this podcast. And for more NP resources, visit FHA.com. Join us again next time as we dissect more medical malpractice cases.